This video covers an overview of the development of the skull and revisits some of the material covered in the embryology of the pharyngeal apparatus presentation to focus on the development of the face, palate, and nasal cavities. An understanding of these developmental processes will enable you to explain the embryologic basis of common clinical anomalies such as craniosynostoses and congenital clefts of the lips and palate. This list of learning objectives will guide your learning of the content of this presentation. Let's begin with a discussion of skull development. As you will learn, the adult skull consists of 28 bones, including the 6 middle ear ossicles, 3 ossicles per middle ear cavity. Most of these bones are interconnected via fibrous joints called sutures. These joints are immobile. There are 3 pairs of synovial joints in the skull. Temporomandibular or TMJ joints between the head of the mandible and mandibular fossa of the temporal bone, between the malleus and incus, and between the incus and stapes bones. There are 2 functional parts of the skull, the neurocranium and the visceral cranium or facial skeleton. The neurocranium contains and protects the brain and sensory organs. It consists of the cranial base or floor of the skull that contains numerous holes called foramina that transmit cranial nerves and blood vessels. The brain rests upon the floor of the skull. The cranial vault is also the calvaria or the skull cap and represents the sides and roof of the skull. The adult skull can be likened to a rigid bony box. As such, the brain is vulnerable to injury when space-occupying lesions occur within this rigid box. These include intracranial bleeding, cerebral swelling or edema following head trauma, tumors, or infections. Unrecognized or poorly treated conditions can depress brain function and lead to death. The visceral cranium contains and protects structures of the upper digestive and respiratory systems, the nasal cavity and the oral cavity. The bones of the facial skeleton form largely by migration and proliferation of neural crest cells. Insufficient numbers or alteration of the function of these cells can produce craniofacial anomalies such as cleft lips and palate. Bones within both the neurocranium and visceral cranium form from 2 types of ossification, endochondral ossification or intramembranous ossification. Endochondral ossification involves a pre-bone template of hyaline cartilage that becomes replaced by bone. Intramembranous ossification involves direct differentiation of sheet-like condensations of mesenchymal cells into osteoblasts. By the time the fetus is ready to be delivered, the cartilage and bone of the cranial base or floor is rather unyielding to movement, which is a good thing, since otherwise nerves and blood vessels passing through foramina would be vulnerable to injury during vaginal delivery. The principal bones of the cranial floor that form via endochondral ossification include the ethmoid, sphenoid, petrous portion of the temporal bone that contains the middle ear and inner ear structures, and the base of the occipital bone located just anterior to the foramen magnum. Intramembranous ossification is the type of bone formation where bone forms within a dense connective tissue sheet or membrane. Here in this illustration we see islands of bone developing in the membrane of the neurocranium, and new bone is laid down at the margins of these islands indicated by the arrows I've drawn in, causing them to grow out radially toward one another where they unite at future sutures in response to the distending forces of the rapidly growing brain. At certain intersections, membrane gaps persist for a period of time after birth. These temporary unmineralized membranes are known as soft spots or fontanelles that can be palpated postnatally. Here is an anterior view of a newborn skull. It is not a miniature version of the adult skull. Proportion-wise, the newborn skull consists mostly of the neurocranium. At birth, the calvarial bones are soft, that is, they are not fully mineralized and not completely fused, permitting some limited mobility. This is important for 2 reasons. 1. Molding of the skull, which is, say, slight overlapping of calvarial bones during descent down the birth canal. and accommodation to the rapid growth of the brain. The brain grows most rapidly during the first 2 years of life when it quadruples in volume, reaching 75% of its adult volume. The remaining 25% of growth occurs during the next 18 years. The facial skeleton progressively enlarges in childhood and adolescence with the development and eruption of the teeth and paranasal sinuses. The newborn skull has more bones than the adult skull. The frontal bone, the bone of the forehead, consists of right and left halves that fuse during the first year of life. They unite along the frontal or metopic suture. In about 8 to 10% of adults, there may be a persistent suture line that may be misinterpreted as a fracture line on an X-ray. A patient history of recent trauma may rule this in or out. Also, the mandible develops as right and left halves that fuse within the first year of life into a single bone. The line of fusion is the mandibular suture or symphysis menti. Shown here is a frontal radiograph of an adult having a persistent metopic suture that may be confused as a fracture line. These illustrations show the superior and lateral aspects of the newborn skull and the various sutures between the calvarial bones. Anteriorly, the frontal bones articulate at the frontal or metopic suture. Posteriorly, they articulate with the parietal bones at the coronal suture. At the intersection of the frontal and parietal bones, we find the anterior fontanelle. Deep to the anterior fontanelle is a large venous blood sinus called the superior sagittal sinus, which drains venous blood from the cerebrum. The right and left parietal bones unite along the sagittal suture, and the parietal bones articulate with the unpaired occipital bone posteriorly along the lambdoid suture. The smaller posterior fontanelle is located at this intersection. There are other minor fontanelles on the lateral aspect of the skull which aren't as important. In the lateral view of the skull, the future external auditory meatus, indicated in green, begins as a ring of bone called the tympanic ring. This grows into a bony canal about 1.5 centimeters in length. Recall that the first pharyngeal cleft or groove persists to form the external auditory meatus, which ends medially at the tympanic membrane or eardrum. Located behind the external auditory meatus is the future mastoid process of the temporal bone. This part of the bone is an example of a traction apophysis that will grow in response to the pull placed on this area of bone by the sternocleidomastoid muscle. The stylomastoid foramen is an opening in the temporal bone between the mastoid process and the styloid process that transmits the facial nerve. This foramen is quite superficial and unprotected in the newborn, and the facial nerve is vulnerable to injury during delivery, especially when forceps are used during delivery. This may produce a facial nerve paralysis of the muscles of facial expression on the affected side. The anterior and posterior fontanelles are the two most clinically important fontanelles, particularly the anterior fontanelle. The anterior fontanelle is located between the paired frontal and parietal bones at the intersection of the frontal, coronal, and sagittal sutures. It is the largest of the fontanelles and is diamond-shaped. It disappears by about 18 months of age. Deep to the fontanelle is the superior sagittal venous sinus. This fontanelle is important clinically, as a depressed fontanelle may indicate an infant that is dehydrated. An elevated or a bulging fontanelle may indicate an infant that has increased circulatory volume, as might occur with excess administration of IV fluid, or increased intracranial pressure, as may occur in a violent physical abuse situation where a baby has been shaken violently to produce a traumatic subdural hemorrhage. The posterior fontanelle is located between the parietal and occipital bones at the intersection of the sagittal and lambdoidal sutures. It is triangular in shape and disappears by the 6th month of life. I will let you identify the structures indicated by the leaders and question marks. Occasionally, some of the cranial vault sutures do not form or they close prematurely, which is referred to clinically as craniosynostoses. This is important to diagnose and treat since it represents a skull that is unable to expand to accommodate the growing brain. This can cause increased pressure on the brain. There are different kinds of synostoses depending upon which specific sutures are involved, and the particular sutures involved determine the resultant shape of the head. The most common type, sagittal synostosis, involves the sagittal suture between the parietal bones and produces a head that is long and narrow, referred to as scaphocephaly, or keel skull. Cause of these synostoses is unknown, and treatment involves surgical removal of strips of bone near the involved sutures to accommodate brain growth. Let us now turn our attention to the development of the face, palate, and nasal cavities. Recall from our previous presentation on pharyngeal arch development that the first arch is often referred to as the mandibular arch and is involved in the formation of the upper and lower jaws. It consisted of two paired processes or prominences called maxillary and mandibular prominences that border on the stomodeum or primitive mouth. Recall also that the skeletal structures within these arches arose from migrating cranial neural crest cells. This slide depicts the embryo as viewed from the front in the illustrations and scanning electron micrograph. The development of the lips, face, and palate occurs between the 4th and 8th weeks of gestation. 5 primordia of neural crest cell enriched mesenchyme develop around the margins of the stomodeum, the primitive mouth or oral opening. A single frontal nasal prominence, paired maxillary prominences, and paired mandibular prominences. I colorized each primordia on the next slide to help orientate you better. In addition, I've added a URL link to another short animation that nicely summarizes this developmental process. In this colorized version, note that the frontal nasal prominence will give rise to the forehead, nose, primary palate, nasal septum, and philtrum with that depressed groove in the midline of the upper lip. The maxillary prominences will give rise to the cheeks, maxillary bone, the secondary palate, and the lateral portions of the upper lip. The mandibular prominences give rise to the lower jaw and lip. Also note that within the frontal nasal prominence there appear bilateral nasal placodes that become the future nostrils, as shown in the next slide. The nasal placodes are thickenings of ectoderm that are surrounded by horseshoe-shaped ridges of mesenchyme. These ridges grow rapidly relative to the placodes, which become recessed and recognized as nasal pits. These ridges divide into medial and lateral portions, respectively called medial and lateral nasal processes or prominences. The medial nasal processes, right and left, grow more rapidly and extend further inferiorly than the lateral nasal processes and fuse with each other in the midline to form the intermaxillary segment and tip of the nose. The lateral nasal processes will form the alae or wings of the nostrils. Simultaneously, as these nasal processes are growing, the maxillary and mandibular prominences begin to grow toward each other. The maxillary prominences eventually make contact with and fuse with the lateral nasal processes. The junction between these components is the nasolacrimal groove, where the nasolacrimal duct will form and descend to its position within the head. The maxillary prominences also merge with the medial nasal prominences or processes to complete the formation of the upper lip. The mandibular prominences eventually merge and fuse to form the lower lip and mandible. Recall from your gross anatomy that the definitive hard palate consisted of 2 bones. The palatine processes of the maxillae, which contain the alveoli or sockets for the upper teeth, and the horizontal plates of the palatine bones. Developmentally, the hard palate is formed from fusion of the primary palate with the secondary palate. The primary palate, delimited by the red dashed lines in this illustration, is a triangular portion of bone that contains the 4 upper incisor teeth and ends at the incisive foramen indicated by the green dot. The remainder of the bony palate is derived from the secondary palate. The illustration in the upper half of this slide depicts the development of the primary and secondary palates. The right and left medial nasal processes fuse to form something called the intermaxillary segment. This midline structure forms, in addition to the philtrum, the part of the maxilla that contains the 4 incisor teeth and the primary palate behind the incisors. Ingrowth of maxillary prominences indicated by the arrows form palatal shelves or plates that grow medially toward each other and eventually fuse to form the secondary palate. Bone develops in both the primary palate and anterior portion of the secondary palate. Bone does not grow in the posterior part of the secondary palate, which eventually forms the soft palate and midline uvula. The illustrations in the lower half of the slide show that as the components of the palate are beginning to form, the nasal septum is developing from the frontal nasal prominence and descending to make contact with the palate. The illustrations on the left are coronal views. Those on the right show the developing palate and nasal septum from below. With continued growth and development, as seen in the scanning electron micrographs on the right, the palatine shelves grow toward each other and begin to fuse in an anterior to posterior direction like a zipper. At this stage, the definitive palate has formed. The incisive foramen marks the site of fusion between the primary palate and secondary palate. This slide shows parasagittal views of the development of the nasal cavities. During the 6th week of development, the nasal pits deepen to become nasal sacs and penetrate the underlying mesenchyme. Initially, the oral nasal membrane separates the nasal pits from the primitive oral cavity. Later, this membrane breaks down to form the primitive choanae for communication between the nasal and oral cavities. Subsequent development of the secondary palate and its fusion with the nasal septum forms the definitive choanae or posterior nasal aperture that connects the right and left nasal cavities with the nasal pharynx. Swellings in the lateral wall of each nasal cavity give rise to the superior, middle, and inferior conchae. We end this video presentation with a brief discussion of orofacial clefting that can occur when there is failure of fusion or merging of tissues near the center of the face. Orofacial clefts are some of the most common birth defects in the U.S. These are often classified as anterior or posterior clefts using the incisive foramen as the landmark. Anterior clefts result from partial or complete lack of fusion of a maxillary prominence with the medial nasal process on one or both sides, leading to a cleft lip, a cleft of the upper jaw, or a cleft between the primary and secondary palates. Posterior clefts occur when the palatine shelves fail to fuse, producing an isolated cleft secondary palate or cleft uvula. Antero-posterior clefts involve a combination of anterior and posterior defects. Less frequent in occurrence are oblique facial clefts and midline clefts of the upper lip. Oblique facial clefts are due to failure of a maxillary prominence to merge with its corresponding lateral nasal process, causing exposure of the nasal lacrimal duct on the surface of the skin. A median cleft lip results from incomplete merging of the right and left medial nasal processes. This slide shows images of newborns with clefts. Panel A shows a newborn with a bilateral cleft lip and primary palate. On the right, this child has a unilateral cleft lip and a complete cleft palate. This slide shows illustrations of newborns with an oblique facial cleft and median cleft lip. This last slide summarizes many of the clefts we just mentioned and different degrees of severity. It should be noted that the lips form between the 4th and 7th weeks of pregnancy, while the roof of the mouth or the palate forms somewhat later, between the 6th and 8th weeks. Cleft lip and cleft palate are distinct malformations based on their embryological formation, even though they often occur together. Children with a cleft lip with or without a cleft palate or an isolated cleft palate alone often have problems with feeding and speaking clearly. The causes of orofacial clefts among most infants are unknown, but likely multifactorial. Recent reports from the Center for Disease Control indicate some factors that increase the chance of having a baby with an orofacial cleft, which include smoking during pregnancy, diabetes, and use of certain medications such as epilepsy drugs. Clefts of the upper lip occur more frequently, approximately 1 in 700 births, than isolated clefts of the secondary palate, which occur in 1 to 1500 births. Cleft lip is more frequent in males than in females, and its incidence varies among populations. Asians and Native Americans have some of the highest rates, about 3.5 per 1,000 live births, whereas African Americans have the lowest rates, 1 in 1,000. The frequency of isolated cleft palate occurs more often in females than in males. In females, the palatal shells fuse approximately 1 week later than in males, which may be related to why isolated palate occurs more frequently in females than males. The photo at the bottom of this slide shows a bifid or cleft uvula in an otherwise intact palate. Fortunately, advanced surgical techniques and support services enable most children with orofacial clefts to do well and lead healthy lives. This ends this video presentation on the development of the skull, face, and palate and discussion of orofacial clefting. Good luck with your studies.